It's recording. All I know is that my assignment, I looked at it and it was garbage. That's why I've basically been redoing it for the last day and a half.
Forever, and I still don't know. I think I have way too many words on my document. But I find comfort in the fact that Dr. Powden said that we're going to struggle through it first, and then we'll learn how to do it later.
Yeah, definitely a big jump from 6 months ago when I was just finishing my undergrad.
Yeah. Well, should we jump right in and ask the first question? So in the assignment description, it said that we should know each other's well enough that we could explain all of them without reference. So, but do you think we could just go through the questions and answer each one for our own and then talk about it as a group, what we thought about each other's? So the first question is, are these tools appropriate for your setting? We could talk about it from the ones that we did and then just have a group discussion about it.
That works.
Okay. Does anyone want to start?
We're all very motivated to be first.
Okay, I'll go first. So, I was of what to do. So I researched 3 different tools that used spinal cord injury, and then I thought that was. I researched what was the most useful outcome of the neck, and then I found the neck and all the research that I found pointed me to another one after I had already done 4 different outcomes, and that's what I put on the end of my clinical bottom line was the MBI, but I didn't do any, I didn't put any numbers for that. It had the widest range of disabilities that it could work towards.
Okay.
Alright, I was just skimming again over everyone's while you're talking. I mean, with mine, I need more to it for the one that I put in, but I just did for the setting I was in more than anything else, because right now I'm not in any setting. I used 3 standard tests that we used for outcome for the shoulder. So, I mean, MRI imaging, able to get a good clinician just by looking at the group of different people with MRI imaging. I can't even speak now. And I mean, mine was simplistic.
Well, no one ever said the tools had to be complicated.
Right.
I know for me, like, I honestly had a hard time finding ones just because I had the hip, and the hip is not, I don't know, I don't feel like there was a lot of hip injuries in the athletic population to begin with. And so trying to find ones was a little bit challenging. And there was one that I found that I really liked, but I could not get access to the journal article that like validated the tool. you had to pay for it, so I had to find a different one that I could actually find research on. But I feel like some of them were applicable, some of them maybe not, because there's one that's like specifically osteoarthritis, and I'm like, usually applied to at least the population I work with. But then I started thinking that, you know, athletic trainers don't work just with athletes. They work in the industrial setting. They work in, you know, with adult populations as well, where, okay, maybe this isn't necessarily applicable for me, but that doesn't mean it's an invalid tool for athletic trainers.
Glad you said that. Because my topic was health-related quality of life for adults. And so I was thinking I personally could use this for my athletes, who I'm assuming are semi-adult, who are like have an injury that's going to require like a lot of time to recover. So like, you know, the mental aspects of it kind of take its toll. So that's how I thought I could use it in my setting. I think you made a really good point, Liz, about it's more than just my setting. It's also about athletes in general. So I was very fortunate to find one article that compared all these health-related quality of life scales. And from that, I pulled the short form 36 and short form 12, which we've read about like 50 million times at this rate. The Nottingham Health Scale, and then the Quality of Well-Being Scale. And I think there wasn't much validity to the first two, if I read my own stuff correctly. I think the Quality of Well-Being was the best one based on this article that I found.
Yeah, I found it interesting when I was looking through yours, the information on the SF-36. That, like, I've heard that referenced so many times. It's like, oh, this is a great one, this is a great one. And then I'm reading and I'm going, oh, it's maybe not as good as what I had led myself to believe. So I was interested in reading that about what you had.
I was surprised too. I just knew, I was like, oh, this is gonna be easy. But that's one. Okay, I just have to prove this, and then the research is based on this article said otherwise.
I think that has something to say too, though, because we use that one as a gold standard. Not necessarily that it is, but we use it a lot and compare to it a lot. But it doesn't necessarily have the best validity and everything else. So I think it's interesting that we do compare to it a lot. And maybe that's more recent than we think. I didn't look at your references to when they were dated, but.
This was in 2011.
Okay.
And it was focused more on rheumatoid conditions.
Yeah. Yeah, I know a couple of my studies, it was like looking at, you know, 50 to 60-year-olds. Okay. And part of me is like, you know, in a high school or collegiate setting, there just aren't that many hip injuries that would really use outcome measures, I feel. I mean, you might get a hip pointer, but I don't know that I would use an outcome measure for a hip pointer. Like, I don't know. You know, most of them are people who have had hip replacements or who have OA or those types of things, where I felt like other topics would be more applicable to the athletic population. But that's just my perspective on things. I did find that some of them had been studied in athletic populations, and there was one that had a sports subscale specifically, which was nice because you can just use that part of the tool instead of having to use the whole thing if you're looking at it athletic populations specifically.
With your hip, I might actually have some articles that deal with femoral neck breaks if you want to, because we had couple football players with a broken hip who was playing at Eastern.
Interesting.
Yeah, we found out after the fact.
Isn't that how it always happens?
Yeah.
Couple hip injuries in my setting. I've had 2 sisters who've had labrum tears in both hips. I've had an avulsion fracture,
Mm-hmm.
the hip flexor from a football player. And because those injuries take so long, like I said, I kind of think of this being something I would use when the injuries are taking a while and I can spend some time with the athlete.
Yeah.
So that's what it brought to mind when your stuff came up. I was like, I wonder what, how it affects them.
Yeah.
Mm-hmm. What's interesting, when I was at NATA, we had there was a discussion one morning about using patient-reported outcomes in pediatric populations. So I definitely went to that one and just talking about how a lot of these have been validated with the adult population, but there's not a lot that have been specifically validated for pediatric populations. There's some out there. I don't remember all of them, but it was just interesting thinking about, I don't know that when I was doing this project, I necessarily thought had they been validated for the younger populations. And one of the things they mentioned was like the readability of the outcome measure. Younger kids aren't going to understand necessarily what stiffness is, or some of the terminology that the adult versions use. They may not understand that, so you may end up getting an invalid result because the kid just doesn't understand what the question is asking. I thought that was an interesting point that I definitely didn't think about when I was looking over the scales. I understand it obviously, but I'm an adult. My high school kids may not understand it, or whether or not a study has been validated in another language. If you work with a population that has a higher Hispanic background, or one of the schools that's close by me has a really high Chin population. So it's just interesting to think about some of those things that, naturally we think, we'll just translate it straight and that should work. But there was actually a number of studies, even when looking at the hip, there were a number of studies that had been specifically validated into another language. So just some thoughts from NATA week.
So for the quality of well-being scale study, it said that that education mattered in that study, and that you needed it needed to be only used with people that were higher educated. Where do you guys think that cutoff is? Like, do you think that people that are in college would be okay to take that, or do you think that we need to think even more deeply of like when in the college years that we could use that?
I think it's trial and error somewhat of just knowing your student. And there's actually, you can copy and paste one of the assessments into the Word document, and then there's a process, it's really easy. You can actually get what's called the Flesch reading scale, I think, and it'll evaluate the document and tell you at what grade level people should be able to read and understand the document. So if you have a question about one of the tools, you can always copy paste into Word and then determine the reading scale, and that'll help you know whether or not this is appropriate for the population you're looking at. And the lecture I went to at NATA said that if you have an 8th grader, you want to find tools that are at least at a 6th grade reading level, because obviously not everybody is going to be at the same reading level just because they're a sophomore in high school. So that was kind of an interesting thing. And they said that 16 was kind of the cutoff between using pediatric ones and using the adult versions. But again, that might be a little bit of trial and error. You may have a 16-year-old that maybe might still need the pediatric versions. So again, just some things I picked up that I found interesting.
Heck, I've seen professional players that need pediatric version.
Yes, I think we've all dealt with those. interesting looking at like all the different ones and trying to figure out which ones can I incorporate into my practice, which ones might I use, and which ones would I not necessarily use. Because I feel like you can get bogged down and you would have 27 different boxes with 27 different outcome measures and you're sitting there picking and choosing. I just don't feel like that's practical, at least not for me. So I would want to find ones that are like the DASH, which is disability of arm, shoulder, hand. That one is like, okay, upper extremity one. And I'd want to find one that was like, okay, this kind of measures the entire lower extremity, just so I'm not trying to find, okay, where's my knee bursitis index or whatever the case may be. You know what I'm saying? Like, I want to try and find ones that are broader, at least to start with. Because I feel like I could get a little bit more specific as I become more comfortable with them, but I feel like to start with, I want to find some broader ones just to get comfortable with using the indexes. So I know with the ones that I found, I don't know that I would use any of those with my population at the moment, but they're there. So it'll be interesting to look through like the rest of the groups and compare like some of the ones that they found and try and narrow down which ones I might use in my practice.
Yeah, I thought mine were a little too specific to be used in clinical practice. That's why I searched for the last one, which was a little more broad, but I found it hard to narrow down what I needed to be looking for, and I didn't know where to go. So maybe for a neck one, maybe I need to look a little more broadly.
I mean, I feel like I've seen, at least heard about, like the neck disability index. So I felt like that one was potentially a good one to use.
Yeah. It said it was the most widely used and widely studied of the cervical spine, so that's why I used it. But I thought the point of the assignment was to find a pathology and 3 outcome measures relating to that pathology. I was wrong. So so that I had to come up with something else.
No, yeah, I initially, when I pulled yours up, I thought, wow, she did 4. She's like going all extra here. Like,
I messed up. I went to turn it in and I was like, oh man, I don't know if I did this right. So I was like, let's just do another.
I think that's been a case for a lot of people. It's like, I don't know if I did this right. Well, I thought that 5 minutes into it.
Yeah.
Time consuming for them. It's way more than the recommended time.
Yeah.
I definitely had like multiple documents pulled up at once. Like I had my matrix and then I had the example, and I'm like switching back and forth. Like, what did the example say? Okay, now look at my studies, and a lot of bouncing back and forth. And I feel like it's with anything, like the more we do it, the more we see it, the more it'll become not habit, but the easier it'll become for us to kind of go through and do this once we've done it a couple times.
Well, talking to some of the class above us, they say the first semester is literally like you've been thrown into a wood chipper.
Yeah, I got to meet Dr. Powden at NATA, which was nice. And I told him it felt like being shoved from behind and you fall into the ocean and you're like, I don't know what's going on. And you're trying not to die and you're trying to find air and breathe. And yeah, that's how I feel. It's just like you're just trying to figure out what's going on because you have no idea what you're doing. But I feel like we'll get there.
Well, 3 weeks down almost.
Yep. So what are like some of the limitations you guys found with your tools?
Oh, you go.
You want me to go?
Yeah.
I think some of the limitations I found were just that they were really specific for certain pathologies, and there was very little evidence about any other pathology. So, and also mine were, it was like, can they go to the bathroom alone? Can they go to the bathroom at all? Are they conscious?
Mm.
So I think a lot of mine were like hotel or hospital useful, but maybe not necessarily in athletic training, because I mean, with spinal cord injuries, like they could be unconscious, and after a car accident that involves the spinal cord, sometimes they're unconscious for a while. So some of them were tailored for that population, and so that made it a little less useful. But the HUDAS and the Neck Disability Index were, I think, the most that could be correlated to athletic training.
Yeah. Those seem to be the easier of the ones that you would put forward, especially because, like, the spinal cord independence measure, you had to, like, read a training manual. And I'm going,
Yeah.
that seems a little extra to have to read a training manual just to learn how to do an assessment. I'm going, okay, I don't think I'm going to use that one because, I mean,
Right.
basically, who has time to go through and read an entire training manual just to learn how to administer a tool? I think mine, like, administering them was pretty easy, but some of the mathematical calculations got a little funky. Like, there was one where you had to take the, like, raw score of it, and then you had to, like, the score was transferred into a scale from 0 to 100, and then you had to times it by 100, or I mean, it was just like a little complicated, but ultimately the final number was like a percentage, so that would be easy to look at and see, okay, they're 70% or whatever. But it's just kind of converting the numbers and doing all the math might be a little more complicated. So.
We need cricket sounds.
So mine was specific to, and I mentioned this earlier, rheumatoid conditions or injuries. So my immediate first thought was, arthritis or whatever. So this is probably an older population. So like you guys were just saying, like, I don't know. I'm just looking at the age brackets for some of this. I don't remember offhand all the exact ages, but more than likely they aren't the 18 to 22 range. They're probably a little bit older than that.
Yeah. Well, because wasn't yours specific for adult populations?
Yeah.
Yeah. So, I mean, I think for the purpose of the assignment, you did what you were supposed to.
Yeah.
Yeah. I think part of the problem is, I think a lot of us get stuck in we treat kids from ages 14 to 22, and we have a hard time sometimes remembering that that's not just who athletic trainers work with. And when we were in Las Vegas, my husband and I went to a Cirque du Soleil show, and there's athletic trainers who work with those people, and we have to remember that we get focused in on our box and what works for us, and sometimes need to remember that athletic trainers work with a broad population. Like, Nicole works with the military population. So I think overall, I hope that this helps other people in other populations see some of the stuff that's out there, and maybe there's something that they would use that maybe just doesn't work for us specifically.
Kind of selfish in the thinking. I'm here to help myself, and we're not supposed to say my athletes.
Right. Yeah, it's I have a patient.
Yeah. Our patients.
Yes, our patients. I definitely think like the outcome tools are effective for what they're trying to measure. So that's good. I know with mine, I felt like any of them could have been appropriately used for what they were trying to measure. Like they had pretty good validity and reliability scores. And mostly they're relatively easy to use, just math is a little bit complicated on them. And none of them were like really long assessments where any of them would take more than maybe 10 minutes to fill out. So that was good. I know some of them, like especially Kelsey, some of yours were like 20 minutes, or I know that was something you had mentioned with some of yours. They were very long assessments to use.
Yeah. I'm sorry, my internet cut out. I don't know that did you ask me a
No.
question?
No, it was
Okay.
quiet.
So I'm looking at the question. So I guess we answered, are these tools appropriate for your setting? The next question is, are any of the tools selected effective? Why or why not?
Well, ironically, I think they're all effective. You just have to have the right population to use them in. I wouldn't say that I would rule out using any of them necessarily. I would need the right patient case to be able to implement them.
Yeah.
Precious, I think yours would be best for a multitude of populations. And then mine were really, really specific. And Stephen's, yours were functional. So if patients are functional, then that's great. But I think it just depends on where your patient's at in life, really.
Mhm.
I think mine were probably the least appropriate for and that it might depend on where you're at, because if you're in an emergency room or in a orthopedic specialty, that it might be useful there, but in the high school they're probably not going to be the most useful.
Yeah. At the very least, I feel like this helps give a baseline for how to find appropriate tools.
Right.
So that way, and no need to reinvent the wheel. Let's look at what other groups have done and what they've come up with, and maybe we'll find something and go, oh, that sounds like one I can use for my setting and my practice. And if not, then fortunately we know how to use Google Scholar or PubMed or any of those other tools to search and find our tools and hopefully find what we need for the purposes we're trying to come up with.
I'm also interested in how often we should use these tools when we use them. So if it's like a marker, right, to figure out how a patient is doing, when do we retest to figure out if they're improving? Are we like helping them figure out the keys or the workarounds to their barriers or whatever is like
Mm-hmm. Well, I know some of the tools, it has a specific time frame listed in the question. Like it might be in the last 2 weeks. So then you would know, okay, this tool needs to be administered every 2 weeks. I would say for the tools that don't necessarily have a specific time frame already incorporated, you could do them every week. You could also wait 3 or 4 weeks. I think again, it just depends on the case and the situation that you're dealing with. If you're trying to, I definitely think you would need to retest if they're at the point where they're trying to return to activity. You would definitely want to retest to see, are they where they need to be? Or you could use it and bring it to a coach and say, this is why this athlete is not returning to play because they're not functional, they're not where they need to be. So I think it kind of depends on where you're at. And again, it'll be trial and error figuring out what works best for us as far as how to incorporate these and when to do them, how often to do them. It's just going to kind of be trial and error, and we'll figure it out along the way.
I also think a place to look for that is in the not just the test retest, but also what the outcome is looking for. So if it's supposed to be a functional measure, then maybe you do it more often. If it's supposed to, depending on what it's looking for, if it's supposed to help the clinician or help the patient or things like that.
We don't have a ticket with this.
Mm-hmm.
So the next question is, do you think other tools may be more appropriate?
I kind of feel like that's a little hard question to ask because I don't know what other tools are out there. But I think if I had a patient, at least with the ones that I did, I feel like if I had a patient with a hip issue, I could definitely use some of the ones that I used. Is it possible there's a more appropriate tool out there? Absolutely. I would need to do more research in order to figure that out and answer that question. So I think it's kind of a hard thing to answer definitively at this point.
I also think it just depends on your patient population. If you were looking for tools that were specific to children, then you would look for the tool that's specific to children, and that would be the most appropriate.
Mm-hmm.
But
Yep.
So the next question is, are the conclusions drawn appropriate? That includes journal articles and matrices.
I'm not exactly sure what that question is asking in particular. I mean, obviously, I feel like the conclusion might be more appropriate.
Right.
I keep looking. I'm like, I'm making sure I'm reading the right questions. I'm like, this says I can too. Like, is that? Yeah.
Yeah. I was reading, and I'm like, I would think they are because we went that route. I mean, granted, mine need more work, but yeah. Next is at least we only have 2 more questions. Because next one is, what are the limitations of these tools?
I think we kind of already touched on that a little bit, just as far as some of the time issues with some of the tools. Some of them are really disease specific as opposed to more broad ranged. Yeah, some of the limitations might be that they're not appropriate for the athletic population, or they've only been studied in X population and you work with Y population. So I kind of think we touched on that a little bit already.
And we've already touched on the last one too. Would we bring these into our clinic? So
yeah, I think it'll be interesting to kind of talk with some of the other classmates and see what they think, as far as, you know, maybe they've looked at ours and they've seen something that we didn't see, or maybe someone has pulled out a specific tool and said, hey, that one will really work for me, or whatever.
end, I'm still trying to understand if I really understand what the criteria really mean. So when you're talking about reliability and validity, like, do I really know what's being presented if it's true? Just listening or just reading the stuff for evidence-based practice in that class, it's like it's just making you think more about what is like true evidence, or the levels of evidence and stuff. So it's just like another thinking that I don't know if I really have yet to determine if a lot of the stuff is truly valid.
Yeah. I kind of want to go back through like the references I listed and using what we learned this week with Dr. Games' class, kind of critically evaluating some of those and going, okay, wait a minute. What are some things I missed? What are some things that might help me better understand if this study is really a good quality study? What is the level of evidence that I've found?
Right.
So yeah, I'm with you on that one. It's kind of an overwhelming, like, have to try and figure out if this is a good study. Like, part of me still gets stuck trying to figure out.
It has to be good.
Well, part of me gets stuck trying to figure out, okay, wait, Cronbach's alpha, and you got this correction, and I'm going, huh? Wait, what's an ANOVA? And I get lost in the statistics of the study.
Yeah.
Fortunately, my husband is a stats teacher, so he helps me out. I'm like, honey, I don't understand. So fortunately, I have him to help me out with some of the stuff. But it's so like, you see all these numbers, and if you don't know what they mean, you can't really evaluate whether it's a good article or not. I mean, obviously the article is going to say we found evidence or not, but you need to be able to evaluate the numbers yourself, I feel like. And that's where I'm getting kind of stuck, is figuring out whether a study, what the statistics say. So you're looking at, the interclass correlation. Well, what the heck does that mean? Or trying to remember what the difference between reliability and validity is an important thing to figure out. Or the inter-class reliability versus the intra-class, or inter-tester versus intra-tester, whatever that distinction was. And just trying to keep in mind like what the numbers are actually telling you when you're looking at an article.
Looks like we're all done. So I'll go ahead and make sure to submit it for all of us. I'll have it uploaded tonight.
Cool.
Awesome.
Have a nice night.
See you guys later.
Yep.
Yeah.
See ya.